Good morning. Thank you, Dr. Khanna. Good morning, Dr. Michel Henry, for this nice conference which Dr. Khanna organizes every year for the benefit of the large number of intervention cardiologists and vascular intervention specialists. Today my topic is the current concepts in management of asymptomatic carotid artery stenosis. The asymptomatic carotid artery stenosis has been under extensive evaluation over the last decade. Asymptomatic carotid artery stenosis is very important because the patient may develop stroke on follow-up. So extracranial carotid artery stenosis, as you know, accounts for up to 20% of the ischemic stroke. The prevalence of asymptomatic carotid artery stenosis in Indian population over 40 years is about 5%. The annual incidence of ipsilateral ischemic stroke in these individuals who are symptomatic with high-grade stenosis is 13%. So the important thing in these patients is to prevent the development of ischemic stroke, recognize them at an early stage. Because there is a risk of stroke, risk of cerebral hypoperfusion, and it can cause cognitive impairment on long term. So the aim of treatment is mainly to prevention of ischemic stroke, which is a catastrophic problem. Optimal management nowadays requires most control of atherosclerotic risk factors, good use of lipid-lowering drugs, avoidance of smoking, strict control of hypertension, and other lifestyle measures like control of diabetes and hypercholesterolemia, which reduces the risk of stroke in these patients with asymptomatic carotid artery stenosis. So current management of the asymptomatic carotid artery stenosis includes medical management, carotid endarterectomy, and carotid artery stenting. But what should be done in those patients, if you encounter a patient with asymptomatic carotid artery stenosis, what should be done in a subgroup? That I shall be discussing. The earlier trial, asymptomatic carotid artery surgery trial, showed the hazard from surgery was about 3%, but then there was long-term benefits. It showed that if these patients are taken up for surgery, the risk of stroke is reduced by 6%. Over the last 40 years, number of trials have been evaluated these patients with carotid artery stenosis. Recent trials have been the ACST2 trial and CREST trial, which recently ACST2 trial, that comparison of the surgery with stenting, has been published, and I shall be discussing that trial also. The earlier trial, the CREST trial, that is comparing the carotid artery stenting with carotid artery endarterectomy, was published earlier, and it showed that both the modes of treatment, whether carotid artery stenting and carotid endarterectomy, were equivalent in most of the things. Stroke and death were equivalent. The only thing was the stroke risk was higher in carotid endarterectomy carotid artery stenting patients as compared to, but most of these strokes were minor strokes. So the major strokes were not significantly different. However, those patients who underwent carotid endarterectomy had higher risk of myocardial infarction. As you can see here, on long-term follow-up also, carotid endarterectomy and carotid artery stenting in this trial, which was published in New England Journal of Medicine, was similar. So, as we go for the 2022, which asymptomatic patients with carotid artery stenosis should be treated? The recent trial has been published on the prevalence of high-risk plaques and the risk of stroke in patients with asymptomatic carotid artery stenosis, which showed that there are some high-risk features in carotid artery asymptomatic patients with carotid artery stenosis, which predict the risk of high stroke in these patients on follow-up. This trial showed that those plaques which are eccolucent, which have lipid-rich necrotic core, which are ulcerated, have high risk of stroke. Also, those patients, asymptomatic patients who show microembolic signals on monitoring, are also at high risk of stroke. So the patient characteristic, that is elderly patients, those patients with evidence of silent cerebral infarction, those patients who have high degree of carotid narrowing, and the plaque morphology features which I discussed are at high risk of stroke. Also, these studies have shown that those plaques which have hemorrhage inside are also at high risk of stroke. So detection of cerebral microemboli and progression of luminal narrowing are predictors of a high risk stroke. This also shows that as the degree of stenosis increases, the risk of stroke also increases. Similarly, if there are equilucent plaques, as you can see here, this is an equilucent plaque. This also has very high risk of stroke. Similarly, the ulcerated plaque and the intraplaque hemorrhages, which can be seen here, also have high risk of stroke. So even in asymptomatic patients, we should try to identify features which can predict the increased risk of stroke, and then these types of patients can be benefited either from carotid endarterectomy or carotid artery stenting. The recent guidelines of European Society of Vascular Surgery showed that asymptomatic patients with 60 to 99% stenosis, carotid endarterectomy should be considered in the presence of one or more imaging characteristics that I have elaborated just now are at increased risk of ipsilateral stroke, and they should be taken up for carotid endarterectomy. As can be seen here, the higher risk of stroke is seen in patients who have spontaneous embolization or equilucent plaque. The hazard ratio is the highest as in these patients. So these patients should be taken up for either surgery or stenting. Those patients who have restenosis after surgery, those patients who have radical neck dissection or high-risk cardiac or pulmonary features, high-risk patients, these are better treated with the help of stent implantation. As compared to that, stenting is risky in those patients who have tortuous arteries, who have severe calcification, have an unfavorable arch anatomy. These patients are at high risk of stenting, so should be taken off carotid endarterectomy. This shows that you can see here that this stenosis is quite severe, and along with that stenosis, there is a thrombus there. So these patients should not be taken up for carotid artery stenting, because once you're pushing a wire and a balloon, this thrombus has high chances of embolization even before you put in a protection device. So those patients who have suspicion of clot, a globular lesion, those patients with dissection or extensive ulceration should not be taken up for carotid artery stenting. Recently, the results of CREST-2 trial were published, and which showed that those patients who are taken up for evidence-based medical management, aggressive medical management, have achievement of the goals. That is, the LDL cholesterol level can be reduced to less than 70 milligram per deciliter. The blood pressure can also be very well controlled, and apart from that, control of other risk factors with the help of these lifestyle measures and medications, and reducing the risk of stroke. So those patients, like these patients, the LDL cholesterol in the subgroup of the cohort reduced from 80 milligram per deciliter to 66 milligram per deciliter. Similarly, the blood pressure was also very well controlled, reducing the risk of stroke. The most recent trial, which was largely awaited, was asymptomatic carotid artery surgery trial, which was published in August 2021. This trial showed that among asymptomatic patients with severe carotid artery stenosis without any recent stroke or transient ischemic cerebral ischemia, both carotid artery stenting and carotid artery endarterectomy can restore patency and reduce long-term stroke risk. And nowadays, both these types of treatment can be performed with about 1% procedural risk of stroke or death. So very good results can be achieved nowadays with the help of latest techniques in both these. So the results showed that both carotid endarterectomy and carotid artery surgery have similar risk now and can be taken up in these patients. Actually, these types of procedures, both endarterectomy and stenting, are complementary procedures. Some patients who cannot be taken up for carotid endarterectomy can be treated with the help of carotid artery stenting. So Good medical management is the cornerstone of management of these patients with asymptomatic carotid artery stenosis and even patients with symptomatic carotid artery stenosis, particularly for asymptomatic patients. In those subgroup of patients who have less than 70% stenosis, medical management with good control of atherosclerotic risk factor is what is required currently. Those patients who have stenosis of more than 70%, and particularly those more than 90%, and those with have unstable features like ulcerated plaque or thrombus, the carotid artery endarterectomy is usually preferred. But if the patient is high-risk surgical candidate, then these patients should be taken up for carotid artery stent implantation under protection. So, ladies and gentlemen, with the help of this current knowledge, let's us evaluate this patient who is asymptomatic but is hypertensive, has diabetes and dyslipidemia, and has carotid bruit on routine examination, and ultrasound shows 50 to 70% stenosis. What should be the management strategy in this patient with 50 to 70% stenosis? With the current knowledge, it shows that optimal medical management is what is required in these subgroup patients, and they do not require carotid artery stenting or endarterectomy, and the blood pressure control and good control of their LDL cholesterol, reduction of HbA1c to less than 7 milligram is what is required in these patients with less than 70% stenosis in asymptomatic patient. As compared to that, in those patients who are having stenosis, severe stenosis, like this patient, this is a 65-year-old male having left main coronary artery stenosis with triple vessel disease and planned for bypass surgery. Carotid artery stenosis evaluation shows that this patient has 80 to 90% stenosis. So on the basis of current knowledge, what should be done in this patient? The current knowledge shows that this patient should be simultaneously taken up for hybrid procedure, that is carotid artery stenting or endarterectomy together with coronary artery bypass graft surgery. The carotid artery stenting immediately followed by carotid artery bypass graft surgery is safe and effective procedure in these patients. So in conclusions, I would say that asymptomatic carotid artery stenosis has high risk of major cardiovascular events, particularly those patients who are having certain features of plaque features are also at high risk of stroke. So intensive risk factor modification will lead to reduction of major cardiovascular events in these patients. So those patients who have severe stenosis and plaque morphology features with vulnerable plaque at high risk of stroke should be taken up for carotid artery endarterectomy or carotid artery stent implantation. Revascularization helps these patients in reducing the risk of stroke. What procedure should be taken is to be decided on the basis of the clinical features, anatomical characteristics, and also importantly, local operator experience giving the risk of stroke to less than 1%, and also the patient preference, whether he wants to undergo carotid endarterectomy or carotid artery stenting procedure should be taken into account in management of these patients. Thank you very much for your patient listening.
Sir, thank you, sir, for the excellent talk.
Thank you very
much. The topic is open for discussion. I think Professor Henry is here. Michel Henry is here. Any comments?
Yes. Excellent talk. I totally agree with you. Maybe just a comment. What do you think about TACAR for asymptomatic patient? Because it's maybe not a new technique. I will discuss that later. For asymptomatic patient, I think with risk, thrombus or very tortuous vessel, maybe it's a good technique with very low risk. What do you think about this technique for asymptomatic patient? Because now it's published that this technique, TACAR, for asymptomatic patient is at very, very low risk. So maybe you could increase indications for asymptomatic patient with this technique. What do you think?
Yes, yes. In those patients who have severe stenosis and the plaque has features which predicts the risk of stroke, this technique is very effective.
Okay.
Dr. Tyagi, Professor Tyagi, Dr.
Yes,
Shin.
please.
See,
Good morning.
Good morning, Professor Tyagi. Regarding, see, most often this asymptomatic carotid artery stenosis, in our practice, we pick up during the evaluation for bypass surgery in most of the patients.
Yes.
Suppose the patient has 70 to 80% stenosis, not beyond 80. What is your routine practice, sir? Do you advocate endarterectomy along with CABG, or do you less than 80% stenosis? I'm completely agree with you with respect to the severe stenosis, more than 80%. Yes, we don't have a any doubt with respect to revascularization of the carotid vasculature. What about less than 80%?
So if the stenosis is not, the plaque characteristic is not unstable plaque, those patients who have not no equilucent plaque or ulcerated plaque or any these characteristics are not there, they can be managed with the help of medical management. Good medical management, reduction of LDL cholesterol to less than 70, control of their diabetes can be done. But as I discussed, the operator experience at that center, what are the results of the procedure? What the, like, if expert like Michel Henry is doing, then he can guarantee that these patients would be having very low risk. Then these patients may be taken up for carotid artery and stenting or carotid endarterectomy. But if the risk of procedure is high, then they should be avoided, because nowadays with the help of latest treatment with the antiplatelet drugs, the reduction LDL cholesterol level to less than 70, these patients, these plaques can be stabilized and risk of stroke can be reduced.
Do you advise your, the cardiothoracic surgeons to do endarterectomy with bypass, or would you stent them and then, give them for bypass?
See, if the lesion, most times it depends on the lesion characteristics. If there is the patient is fit and the plaque characteristic is that it is not thrombotic, then one can go ahead with stent implantation, and simultaneously then the patient can be taken up for carotid, the bypass surgery also, after maybe if a day later on or so.
Dr. Tyagi, another question. Do you consider a patient with asymptomatic, consider as asymptomatic with silent brain infarct? Is for you asymptomatic? And in that case, a patient 50% stenosis, silent brain infarct, is indication or not?
See, if the patient is having silent brain infarcts, then this patient is at a higher risk of stroke. Then if the patient has stenosis of more than 50%, in fact, that should be considered symptomatic.
Yeah.
Okay. If you are identifying developing silent strokes this patient is having, and reduction of the cerebral reserve is happening, then these patients should be management more aggressively. Maybe carotid artery stenting may be required in these patients.
Okay.
Professor Tyagi, you have very vast experience in aorta arteritis.
Yes.
In asymptomatics, what is your strategy now? Do you go for balloon angioplasty or stenting?
See, in aortoarteritis, there is another problem. The risk of restenosis with the help of stent implantation is higher. So if the patient is symptomatic, if patient has severe stenosis, 90 to 99%, then only we go ahead with the angioplasty procedure. Otherwise, for 50% stenosis, other arteries flowing, most importantly is to control the activity of the disease, control of with the help of medications, control their ESR, CRP, and reduce the activity to prevent the progression of disease. And most of the time, patient continue to do well. But if you intervene, do angioplasty, and put in a stent, then restenosis may be at a high, they may be at higher risk of restenosis.
Any other questions? Dr. Khanna is able to hear us. So, sir, thank you, sir, for the excellent talk.
Thank you, Dr. Ashokan. Nice to see you here.
Yes.
Thank you, sir. Thank you, sir.
Thank you.
Thanks.